Journal clubs.
Yeah, Journal Club. And I have added a short, if we have time, I'll just one quiz question, if it is possible to include, so that.
It's possible, sir. I think we have a option for chat and question answers, I think so.
So if there are any residents and they, so that we can tell that who gave the correct, or if there are more than one correct entry, so just to evoke interest so that we have more people.
Sir, you can start.
Yes, sir. We have quite a few number of residents joining in. So
Nice.
quite many more will be trickling in soon.
Nice.
So I think on behalf of the Neuro Ophthalmology section, we all welcome you to today's webinar, which is being held by Professor Arun Kaur from JV Pant Hospital in New Delhi. He and his team are going to present two very interesting cases of tropical neuro-ophthalmology and a short journal club. And I think I'll hand it over to you, Professor Arun Kaur.
Yeah.
Yes, sir.
Yeah, so it's a great beginning that at least we have started this, the cases and the Journal Club. I think Dr. Arjun can start, and whenever anybody has a question, so they can raise their hands. If at any point you want to discuss something, so we'll be more than happy to answer your queries. Otherwise, we'll discuss the case and then we can take the discussion at the end. So you can, by the time you can send in any questions or comments, they are welcome. So I think Dr. Arjun, you can please start.
So good evening, everyone. My name is Dr. Arjun. I'm a neurology resident from GB Pant Hospital. Before starting, I would like to thank the Indian Academy of Neurology for giving me an opportunity in this national platform to present these two cases. I hope all of you will benefit from this. I would also like to thank my professor, Dr. Arun Kaul sir, and all the faculties from GB Pant Hospital for providing me with this opportunity. So without any delay, I would like to go on to the to the slides. So I will be presenting tropical dance. That is the heading of my presentation today. So I'll be presenting two cases. The cases will be back to back and the discussion will be done after both these cases. So the first case, so it is an 18-year-old female. She's hailing from Delhi. She initially presented to our emergency with headache, and she had multiple secondary characters for a headache, like she had a worsening at the time of night, nocturnal worsening. She had worsening while leaning forward, and early morning worsening of headaches were also there. There was prolonged fever, which lasted for a period of over 1 month. She also had diplopia and difficulty in deglutition over the past 2 weeks. There were no other prior comorbidities or addictions. Could you go back to the previous slide? So she had a past history of pulmonary TB. The pulmonary TB was microbiologically confirmed, and she had taken a course of ATT for around 6 months, and this was around 2 years back. So she was treated with antibiotics and steroids from an outside hospital, but she had no improvement in her symptoms. So she presented to us, and on examination, she was conscious. She was following commands. On examination, fundus, there was grade 2 papilledema. There was bilateral lateral rectus palsy, and she also had a right UMN facial palsy. She was moving all 4 limbs normally, and all the reflexes were normal. And on examination, she had meningeal signs in the form of neck stiffness and kernicks. So a provisional diagnosis of chronic meningoencephalitis was made in this case. Next slide. So this was the initial CT at the time of presentation to our emergency. So this is an NCCT head, axial cuts, where you can see that the ventricles are quite dilated, both the lateral ventricles as well as the third ventricle. There is opening up of temporal horns of the lateral ventricle, and there is periventricular hypodensity, mostly suggestive of periventricular ooze. Next slide. So on this setting, we decided to proceed with a guarded lumbar puncture because she had papilledema. And the lumbar puncture revealed 4 cells, 100% lymphocytes. The sugar was around 15. The RBS at that time was 110. Protein was 175. So we also sent a CBNAT. The CBNAT came out positive for TB, and it was rifampicin resistance. So in this setting, a probable diagnosis of TB, meningoencephalitis, was kept. we also proceeded with the CT chest and abdomen, which revealed pulmonary infiltrates. Since there was rifampicin resistance, we decided to give the patient treatment MBR, and it was started from Dodge Center, which included linezolid, moxifloxacin, cycloserine, bedaquiline, clofazimine, as well as dexamethasone. So she was admitted for a period of around 1 month, and following 2 weeks following the admission, there was improvement in her headache and fever. And later, she was sent back home and asked to continue the drugs. So after around 15 days, so 15 days later, after she left our hospital, she again came back to our emergency, and this time she had worsening of headache. There was recurrence of fever, and the new symptom which happened at that time was she had an altered sensorium and an acute onset left-sided weakness. So this left-sided weakness was the one which prompted them to bring the patient again to our emergency. So on examination, at this time she was conscious, but she was aphasic. She was following gestural commands with a grade 1 power of left upper and left lower limb. So this is the peculiar eye movements that we observed in this case. Yeah. Could you play the video once more so that everyone can see it once more? So I hope all of you can appreciate that there are non-rhythmic, rapid, involuntary eye movements. You can see there are both horizontal as well as vertical eye movements, and the movements are in different directions also. So this prompted us to consider a possibility of opsoclonus in this patient. So this was the fundus examination done on the second visit. So the first visit, she had a grade 2 papilledema. So in the second visit, you can see almost grade 4 papilledema was there. So she had already come with an MRI brain from outside in the second visit. Next slide. So you can see this is the MRI brain. You can see both axial as well as sagittal cuts. You can clearly, I hope you can appreciate the meningeal enhancement. There was hydrocephalus. There was no significant worsening of hydrocephalus in the second image, and there were no significant basal exudates. So this is the T1 contrast images which you're seeing. It shows meningeal enhancement as well as hydrocephalus. Next. So this is the diffusion weighted image, and I hope you can see there was diffusion restriction predominantly in the right caudate nucleus, both thalami. In the there is diffusion restriction in the pons, and you can also see in the middle cerebellar peduncle some portions of the cerebellum, especially the cerebellar vermis as well as the cerebellar hemispheres. So this was most probably because of a vasculitic infarct, and this must have been the reason why she developed the hemiplegia. Coming on to the next slide. So you can see this was a repeat CT scan which was done after she presented to our emergency, where you can see the hydrocephalus has worsened. You can see the temporal horns of lateral ventricle has opened up much more. And so in the first setting, when the patient initially came to us, she already had a hydrocephalus and grade 2 papilledema. So neurosurgery opinion was taken at that time, and we had initially decided to proceed with a shunt surgery, but the attenders were not willing for the same. In the second setting, and the patient had also improved after starting antibiotics and steroids. But in the second visit, because of the worsening hydrocephalus, papilledema, altered sensorium, we persisted for a shunt, and finally the shunt was performed. You can see the VP shunt was there in situ for this patient. So following the VP shunt surgery, around 1 week later, there was significant improvement in the sensorium of the patient, but the eye movement abnormalities persisted. So she came to us after we had again discharged her. There was improvement in the sensorium. We had a follow-up of this case for the next 3 months. And she had come, and there was improvement in the sensorium also. But still the eye movement abnormalities, which was initially seen in the first video, was still persisting. So coming to the next case. So case number 2. So this is the case of a 4-year-old child. She's hailing from Delhi. Her birth and developmental history up until the start of the illness was normal. So she presented to us with complaints of sudden jerky movements in all four limbs with recurrent falls over the past 6 months. So there was progressive cognitive impairment with regression of the previously attained language and the motor milestones over the past 6 months. But there was no history of any limb weakness or ataxia prior to the onset of falls. There was no prior illness, and the vaccination status of this patient was unknown. There was no past history of any fever with rashes. So the parents, they started noticing erratic eye movements over the past 4 months, and this was what prompted them to consult a physician. So I'll play the first video. So I hope you can appreciate there are sudden jerky movements in all four limbs, upper as well as lower limbs. The movements are slow. Probably this is a slow myoclonus in this patient. Please play the second video. So please closely observe. So please closely observe this video. You can see hello. So you can see in this image, there are erratic eye movements for this patient in both directions, both vertical as well as horizontal, and it has a slow phase as well as a fast phase. Coming to the next slide. So the differentials at this moment of time, which was considered, include since the patient presented to us with again erratic eye movements, which was consistent with a diagnosis of opsoclonus, and she also had myoclonus, a differential of opsoclonus myoclonus ataxia syndrome was considered. So in this patient, the first differential that we considered was a paraneoplastic disease. And in a patient who's less than 5 years, the first cancer to come to our mind was a neuroblastoma. Then the second possibility is a post-infectious cause. Third possibility is encephalitis, which is infectious viral. The fourth possibility is a toxic and metabolic encephalopathy. And the fifth one was an autoimmune encephalitis, that is NMDAR encephalitis. So we proceeded to evaluate the patient in these terms. So on examination, the general physical examination was unremarkable. The patient was conscious and was following simple gestural commands. So there were myoclonic jerks involving all four limbs, which exhibited a very slow relaxation phase. So motor system examination revealed rigidity with intact power and reflexes in all four limbs. So this was the EEG of the patient, and I hope you can appreciate there were periodic discharges, high amplitude, slow discharges. These are the characteristic Rademacher complexes which you see in SSPE. So next. So we proceeded with an MRI brain, and I hope you can appreciate in the MRI brain, there are periventricular as well as subcortical, especially in the frontal lobe, T2 flare, white matter hyperintensities. Next slide. So we decided to proceed with a lumbar puncture, and because the patient had progressive cognitive decline, she had myoclonic jerks, opsoclonus, and white matter hyperintensities in the MRI brain, we decided to send the CSF for IgG anti-measles antibody, and it revealed a CSF serum reference quotient of 5.5, and the reference range was less than 1.3. Next. So a CECT abdomen and thorax was also done, and this was predominantly done as a part of opsoclonus myoclonus ataxia syndrome workup because we have to detect the presence of a neuroblastoma in this case, but the CECT thorax abdomen came out normal. So after the examination and evaluation, a clinical diagnosis of SSP was made as per the Dykens criteria. So the Dykens criteria has two major criteria and minor criteria, where we require two major and one minor. So the major criteria fitting in our case was myoclonic jerks and gradually progressive cognitive decline. And the second one was a positive CSF anti-measles antibody. Then the minor criteria was the presence of CSF protein, where out of the CSF protein, CSF immunoglobulin level was more than 20% of the total CSF protein. And we also had an EG marker, that is the Rademacher complexes. So after the diagnosis of SSP, the child was given off-label treatment with isoprenosin, started at around 100 milligram per kilogram per day. And she was given syrup carbamazepine for the myoclonic jerks and syrup clobazam for the myoclonic jerks. But unfortunately, she continued to deteriorate despite the treatment, and she was bed-bound in the follow-up visit. So this is the overview of the two cases. If anyone has any questions before we move on to the discussion.
I think you can just start with the discussion. We'll have the questions at the later time.
Okay. So my first case was a case of opsoclonus, and the second case was a case of opsoclonus myoclonus ataxia syndrome. So coming to the etymology of the medical terminologies of opsoclonus myoclonus. So the term opsoclonus is actually derived from the ancient Greek word ops, which means eyes, and klonos, which means violent and confusing movements, denoting the uncontrolled eye movements. So it was believed that the Polish neurologist Orzechowski and the pediatrician Godziewski, so they were the ones who initially coined the term opsoclonus, and they described this in a patient with disorganized eye movements at a scientific meeting way back in 1924 in Kiev. Next slide. So the first case report, which was actually a case series, it was published in 1962 by Mr. Kinsborn, and this is why opsoclonus myoclonus ataxia syndrome is also known as Kinsborn syndrome or the dancing eye syndrome. So it is in his case series, it was written that he has reported 6 cases with myoclonic status. So the acute onset of myoclonic status, so that means in his cases, all of them had myoclonic epilepsy and they had altered sensorium. And especially there were erratic movements involving the extraocular muscles, which was unaccompanied by any EEG evidence of discharges. Next slide. So coming to what is an opsoclonus. So opsoclonus is conjugate, involuntarily, extremely large amplitude, saccadic intrusions, and this was in all directions without any intersaccadic interval. So whenever a patient comes to us with opsoclonus, our focus should be on the brainstem, especially in the pontine area, the pontine tegmentum. So in the pontine tegmentum, we have something called as the omnipose nucleus. The omnipose nucleus has an inhibitory control over the burst nucleus. So whenever there is any dysfunction of the omnipose nucleus in pons, so that lifts off the inhibition over the burst nucleus. So the burst nucleus is the one which controls the saccades. So if the inhibition is taken away, the saccadic intrusions come into play. And that is why we get abnormal saccadic intrusions without intersaccadic interval. So opsoclonus can also be divided into 2, fast as well as slow opsoclonus. This is mainly based on the frequency. If the frequency of the opsoclonus is around 20 hertz, it is called fast opsoclonus. And if it is less than 10 hertz, it would be slow opsoclonus. So in the fast opsoclonus, this is the one which is classically described in children less than 5 years, especially in those who have a paraneoplastic manifestation following a neuroblastoma, where there are erratic high amplitude eye movements with a frequency of more than 20 hertz. Slow opsoclonus, the frequency is less than 10 hertz, usually in and around the range of 1 to 5 hertz. And this is seen in patients with pontine lesions. For example, we are having a pontine stroke where a patient is coming to us in a locked-in syndrome state, or if he is having demyelination of the pons, or if he is having any other structural abnormality, and he continues to recover from this, that is when we get slow opsoclonus. So as I said earlier, opsoclonus, we must always look for pontine lesions. So the causes, the most common cause in children less than 5 years, and in less than 2 years, the most common cause is paraneoplastic, secondary to neuroblastoma. The second most common cause is post-infectious. In adults, the most common cause is still post-infectious, but we should always rule out other causes like toxic, metabolic, vascular, structural, and autoimmune. Next slide. So opsoclonus myoclonus ataxia syndrome was previously called the dancing eye syndrome. So the mean age of presentation was 18 months, that is less than 2 years. So it falls in the spectrum of acquired cerebellar ataxias of childhood. And sometimes the patient comes to us with only cerebellar ataxia. And later in the course of the disease, they may develop opsoclonus and myoclonus. So most of these patients, initial stages, we diagnose them as post-infectious cerebellitis and we treat and evaluate for the ataxia. But later on, once the opsoclonus and myoclonus starts to form, then we think about lesions in the pons. So opsoclonus are saccadic intrusions which produce chaotic eye movements, unlike nystagmus. So the differentiating feature between opsoclonus as well as ocular flutter, which is the other movement disorder which behaves as opsoclonus. So ocular flutter, the amplitude will be less and it will be in the horizontal direction, while opsoclonus will be erratic in all directions. We can get it vertically, horizontally, and sometimes even torsional. And opsoclonus can have both types, fast as well as slow types. Next slide. So based on an expert panel recommendation, a diagnosis of OMAS is made only when 3 of the following 4 features are present. That is opsoclonus, myoclonus or ataxia, behavioral changes or sleep disturbance, neuroblastoma. I hope you remember the second case which I presented. In the second case of SSP, we had opsoclonus, we had myoclonus, and we had behavioral changes and cognitive decline. So how to, if a patient is having mild opsoclonus and if we are having a doubt whether it's opsoclonus, a test can be performed to make it more obvious. That is a squeeze test. That is, we ask the child to close the eye against the examiner's resistance. Also, if we are asking them to perform saccades and fix the eye on a particular point, that also brings out the opsoclonus. And opsoclonus would persist in sleep. So peripheral neuroblastomas in 50% of children is seen in OMAS, and infective causes, the things which we should rule out are EBV, mycoplasma, streptococci, HIV, dengue, rickettsial infection, and Lyme's disease. Next slide. So in a patient with OMAS and neuroblastoma, what are the biomarkers which should be done? So CSF B cell expansion biomarkers should be done. Then CSF oligochronal bands, although it is not specific or sensitive, but still intrathecal IgG synthesis can be seen in 58% of patients with untreated OMAS. CSF neopterin, which is a sign or which is a marker of cellular immune activation, and it is elevated in majority of the patients of OMAS. In CSF cytokines and chemokines, and neuronal damage markers like neurofilament light chain levels. So the important thing is any child who comes to us with OMAS less than 5 years, we should evaluate for peripheral neuroblastic tumors. So the evaluation include MRI brain as well as the MRI of the abdomen and pelvis, CT or ultrasound. But the best investigation would always be to go for an FDG PET scan so that it can screen the entire body for the presence of crest cell tumors. Another investigation which can be done is urine catecholamines, and this must be done which supports the presence of catecholamine secreting tumors, that is neuroblastoma. If MIBG scintigraphy scan is available in your setting, you can also go for that to identify the presence of neuroblastoma. Next slide. So the recommendations for the initial investigations are a routine blood test. So any patient who comes with fever, that is infection-associated opsoclonus with myoclonus, we should always send a CSF biofire to rule out the common viral causes of the same, that is CMV, Epstein-Barr virus, varicella zoster virus, HHV6, West Nile virus, adenovirus, and influenza. Then other routine CSF evaluation should be done, including the CSF IgG and OCD if available. Neuroimaging, MRI brain with focus on the pons, and we must also look for any lesions in the posterior fossa or the cerebellum. Then laboratory screening for neuroblastoma, which I have already mentioned earlier, especially MRI of the MRI, PET scan of whole body PET, and MIBG scintigraphy if available. Next slide. So there is actually a rating scale for OMAS, which is called the Mitchell and Pike rating scale. So the importance of rating scale is to see the response to treatment. So it has mainly six items in the rating scale. So we have stance, we have gait, we have arm and hand function. So this is for the assessment of ataxia. Then we have opsoclonus. Then we also have mood and behavioral disorders, which is the third part, and finally speech. Next slide. So coming to the treatment algorithm, where a patient comes to us with opsoclonus myoclonus ataxia syndrome. So a patient can have two variety of presentation. If a patient comes to us with a febrile illness presenting with OMAs, we should work up for the causes of the same, bacterial, viral, and other causes. And if an organism has been detected and the patient is febrile, we should give appropriate antibiotics and the treatment, antibiotics, antivirals, etc. So the majority of the treatment algorithm comes in cases where we have an idiopathic cause, where we have autoimmune cases, paraneoplastic cases, or the post-infectious cases. So I'll be discussing about that in detail. So we must investigate such patients, the investigation I had mentioned earlier. So if a neuroblastoma is identified, further investigation and treatment should proceed in that manner. Suppose if a neuroblastoma is not there and the patient is presenting us in less than 2 weeks. So we have two ways to treat the patient, either upfront management or the second is escalating management. Upfront is when we give the immediate management and then we immediately go on to give immunosuppressants. Escalating management is stepwise. We initially give the acute management, we look for response. If there is no response, we then go for the second line treatment. So upfront management, we have prednisolone, ACTH, IV NP pulses or oral dexamethasone, plus IVIG or plasmapheresis, and later we immediately go on to either cyclophosphamide or rituximab as maintenance therapy. So coming to the escalating treatment, that is when we give steroid pulses or ACTH. Then we assess for response at 4 weeks. So if response is not there, we can again try 2 weeks more pulses of dexamethasone. But if inadequate response is there, that is when we give rituximab or cyclophosphamide. So insufficient response is when we have insufficient response after 2 months. That is when we switch over. So suppose if we are giving cyclophosphamide and if adequate response is not there, we switch over to rituximab after 2 months. Similarly, if rituximab is given and inadequate response is there, we switch on to cyclophosphamide. So following the management, how do we define remission? So remission is always defined by looking at the Mitchell-Pike rating scale. Suppose if there is disappearance of symptoms for 2 consecutive standardized scoring at 4 weekly intervals, that is the score should be 0 in categories of stance, gait, arm and hand function, and the score should be either 0 or 1 in the categories of behavior, speech and language. So if these scores are not attained, we say that it is insufficient response. Next slide. So these are the various drugs which are given. So considering the steroids, we have 2 options. We can either give dexamethasone or methylprednisolone. Methylprednisolone pulse is given as 30 milligram per kilogram per day for 3 to 5 days. And it is repeated every monthly. But the interesting thing is, it is said that we should give for at least a period of 6 to 12 months. And the steroid should be tapered slowly over a period of 12 months because the chances of relapses are high in this case. So if we also have a choice of giving dexamethasone, that is oral, where doses of 20 milligram per meter square per day is given in 2 divided doses on 3 consecutive days. And this is repeated every 4 weekly, again for a period of 6 to 12 months. So another option for this case in acute management is we can try ACTH in these patients, where 75 international units per meter square is given intramuscularly. It is given twice daily for 1 week, once daily for 1 week, and then alternate days for 2 weeks, and then a gradual wean off is done over 11 months. So if there is inadequate response to this, then we can consider IVIG, which is given as 2 gram per kilogram body weight over 2 to 5 days, and it is repeated every 4 weekly, which we can repeat up to 12 months. Next slide. So this was the literature review. So the first one is an infection-associated opsoclonus, a retrospective case record analysis and review of literature. So this was published in the Journal of Child Neurology in the year 2020. So you can see we have a case series of 15 children. So out of which 6 children had a febrile illness, associated opsoclonus with febrile illness. And you can see that one of these patients had an acute cerebralitis, one had an SSP, one had a scrub typhus, one had TB meningitis, one had mumps encephalitis. So all these patients, all the 6 out, all of them, like TB meningitis was treated with ATP, then SSP was given isoprenosin, then acute cerebralitis was given steroids. So they were treated as infection-associated opsoclonus, and there was significant improvement in all these patients except the case with SSP, who continued to deteriorate. Next slide. So this is the case report of adult onset opsoclonus myoclonus syndrome. Next. So you can see here, can you go back? So you can see here, so this was a case series of 21 patients, that is 21 patients in Mayo Clinic, and they also had a registry of 116 previously reported cases of adult onset OMAS. And you can see that cancer was detected in 3 patients, that is breast adenocarcinoma in 2 and small cell cancer of lung in 1. The rest of them were para-infectious, autoimmune, and had multiple other etiologies. And finally, the cause of death in most of these patients was paraneoplastic origin, that is 60 of 116, and most common cancer being small cell carcinoma of lung, followed by breast. And the antibody testing for paraneoplastic encephalitis came out positive for anti-neuronal nuclear antibody, that is anti-Re antibody in 15 patients. So other 35 patients had a para-infectious etiology, 15 were associated with HIV, 7 with toxic and metabolic causes, and 2 with autoimmune. And in the autoimmune, both of them were positive for NMDAR. Next slide. So our case of SSP, we later published it in JAMA in July 2025, opsoclonus myoclonus ataxia syndrome in a patient with SSP. Next slide. So the take-home points from this presentation. So a patient who's coming to you with OMAS, if the child is less than 2 years, or if the child is less than 5 years also, we should always look for peripheral neuroendocrine tumors like neuroblastoma. Paraneoplastic and autoimmune panel should be sent for patients, especially with MRI negative OMAS in adults. Intense immunosuppression would be required for autoimmune mediated causes of OMAS, and steroids should be tapered slowly over 12 months. And there is a role of ACTH in treatment refractory cases. Thank you.
Yes. Thank you, Dr. Arjun. So it's a very good series of interesting patients who are presented with opsoclonus and myoclonus. You had concentrated on your discussion about how to approach a case of opsoclonus myoclonus syndrome and how to look at the early stages of these diseases before they become full-blown disorders. And so we have a lot of questions that the audiences and the panelists have asking. So one of the first question is, before I ask, very rare cases. We have tuberculosis presenting with opsoclonus and SSP presenting opsoclonus. Very unusual cases, that is infections causing opsoclonus, that we have discussed. So I'll ask the first question that the people are asking. In the first case, I think the case with SSP, carbamazepine, you have mentioned that carbamazepine was used in the case of myoclonic seizures. So most of the neurologists and neurology trainees have been taught that carbamazepine is avoided in any myoclonic seizures or myoclonic epilepsy syndromes.
Yes.
So can you explain them why carbamazepine was very useful in SSP patients?
So it is seen that carbamazepine is a good drug for controlling myoclonic jerks in SSP, and it is useful only in SSP. That was why we had given carbamazepine for the control of myoclonic jerks.
So that's what. So since we all understand that myoclonic epilepsies are syndromes of different channels, I'm not an epilepsy expert here, but yes, a large series and in a good review by Professor Ravinder Garg, and I think in 2013 in AIN, one of the few anti-epileptics that he recommends, Dr. Ravi Garg sees a lot of SSP, the largest series in India. He recommends carbamazepine in these patients, and other anti-epileptics like valproate, clobazam, levetiracetam can all be used. But the first thing that he recommends in his paper is carbamazepine.
Just a small comment for the residents that because the origin of the myoclonus in SSP, it's not very clear that where does it arise. And all typical the myoclonus we see in like in GME or other classical myoclonus we see is in a cortical myoclonus. So for cortical myoclonus, carbamazepine is contraindicated. So your point is very well taken. Everybody has raised that question. But here the myoclonus is not cortical. So in this myoclonus, even the sodium channel blockers like carbamazepine, it has, as Dr. Karthik has already told, that it works very well. Yeah, go ahead. The second question.
And the another question that everyone is asking is, what if this patient, both of these patients are non-immunological? First one is a stroke causing opsoclonus. The second is a SSP causing myoclonus, in which you cannot give immunomodulation like steroids, ACTH, or any other therapy. So how do you treat these patients? Opsoclonus per se, these are very disabling eye movements. So how do you treat these patients? What drugs do you recommend in these group of patients?
Yeah, Arjun, you want to say he was
Yeah.
saying.
Yeah. So as I mentioned earlier, we have to see the cause. So what the cause is, whether it is infective or whether it's post-infective, immune-mediated or para-infectious or even paraneoplastic. So if it is infectious, if the patient is having fever at the time of presentation, and if we are having evidence of a particular infection, we will give treatment for that particular infection. Like in my case, which I said first, like a TB meningitis patient who came to us with stroke. The cause of opsoclonus in our patient was because of stroke in the pons, in the pontine tegmentum, in the area of the omnipose cells. So in such a patient, like we can only give treatment for TB. But if a patient comes to us with possible MRA negative cases of OMAS, that is when we don't have a cause and we evaluate and find out that it is para-infectious or autoimmune. That is when the management which I mentioned, where we can give immunosuppressive drugs, we can give steroids and IVIG works. If you are getting an infective cause, we probably go in terms of infection, treatment with antibiotics and antivirals.
So how did you manage this patient with TB meningitis and a stroke?
Yeah. So TB meningitis, we had given because it was MDR TB, we had given the MDR regimen of drugs, ATD, and we had also given steroids. Then we also performed a VP shunt in that patient with obstructive hydrocephalus. So I had mentioned it also. In the follow-up, there was no improvement in the eye movements, but the patient's sensorium had improved.
So yes, so in those, so for all the residents who are having difficulty in managing this refractory nystagmus, refractory eye movement disorders, you can always try clonazepam or gabapentin or topiramate in such group of patients. These are not the basic treatment of the underlying cause, but they do help symptomatically in managing the abnormal eye. So most of these patients, since if the frequency is too high, the patients may not notice. Once the frequency slows down so that it interferes your fixation on your fovea and the central macula, then at that time you will have difficulty in focus. So initially the patient may not complain of blurring of vision when the frequency is too high. So if that high frequency, the patient may not even notice the oscillopsia. But once the frequency slows down, then the patient will see. So in those group of patients, if you can try, the best treatment that they say is gabapentin, followed by clonazepam. Then you have other antiepileptics can be tried, like topiramate and as well as valproate also. And I think we have much more cases. I think we have cases regarding the management of tuberculosis. Some resident is asking, if you have a high protein in TB meningitis, would you still go for a VP shunting with the risk of blocking? I think it's a neuroinfection question, but I think we can still take it on. Anyone wants to answer? High protein in VP shunting, do you still consider as a issue with the VP shunting?
Okay, basically this is always a question because the neurosurgeons, in fact, this topic of a VP shunting in a TBM patient, what should be the exact time when you do the VP shunting, it's still debatable. There are large literature is in the favor of early shunting, but there are good number of people who say that if the protein is high, there's a risk of shunt blockage. So, but EVD per se, although the neurosurgeons favor, but it has a high risk of infection. And in TBM patients, whatever we do, we mostly do this the VP shunting. Of course, now there are programmable shunts, and the high protein usually in our setup they say if it is more than 250, then there's definitely a risk of shunt blockage. But with the steroids and other anti-inflammatory, when they are available, you can put in a shunt, especially in such cases where there's an emergency and the patient has a risk of herniation. EVD, I have a limited experience with what we have seen. They mostly get infected and the patient develops a secondary bacterial meningitis. It is very difficult to maintain an EVD drain for more than 1 or 2 days in the ICU setting.
Yes, sir. Completely agree with you there, sir. EVD, when you're putting a patient of tubercular meningitis in a ward in which you are not able to guarantee a clean environment, especially when the patient is on steroids, uh, then it's a risky procedure compared to a VP shunt. The VP shunt can eventually block, but if you're giving steroids, the inflammation does go down. One of the first things that occurs once you treat a TB meningitis is the sugars start climbing up, then the cells come down, then the proteins come down. So once the inflammation and the response wanes down, the CSF protein will also come down eventually, unless and until you have pockets of CSF in which there is extensive adhesion in which the pockets of CSF, then the protein may not come down in that group of patients. And any other questions, I think? Yes. So one of them was asking, what is anatomical lesions responsible for opsoclonus? I think you can just show your earlier presentation in which you have, I don't think the opsoclonus patient had a very good localization. I mean, the SSP patient didn't have a very good MRI lesion at that spot, but the TB meningitis patient had a very good infarct at that spot. Can you just show to all the residents where exactly the nuclear raphe interpositors, which is responsible for opsoclonus, is?
So the interpost, the omnipost nuclei is present in the pontine tegmentum. That is the area that you can in the image also I had shown. That is the area where the infarct was seen. Then
the first presentation, yeah. I think there is that slide.
Yeah, second image.
Not next slide number. Just tell them.
Slide
number 10.
Slide number 10.
Yeah, slide number 10. Yeah. So I think you can see the slide. You can zoom in on the first 6 images. Yes, you can see. There are infarcts in the pons, and yes, so there are infarct in the pons. There even in the first 2 slides itself, first 2 rows itself, you can see the infarct. So this is where the omnipause neurons were, and these are where. And what to say? If there is no further, you can see that's what caused the loss of omnipause neurons there and caused opsoclonus. So in these subgroup of patients, I think treatment with clonazepam, gabapentin will help with those eye movements, apart from whatever treatment you are giving for TB meningitis in this group of patients. So I think there's a lot of questions regarding tubercular meningitis and its management. I think a lot of people have doubts regarding the management of TB. In case of CSF more than 400 proteins, giving steroids for more than 8 to 10 days, no CSF or any other evidence. So I think all this TB meningitis management has to be done on a case-to-case basis. Even if they're not improving, you can hike up the steroid dose or give pulse steroids also. So there are some groups which give higher immunomodulation. So that the sub-Saharan and the African groups and some Indian studies give thalidomide to reduce the CSF inflammation and anti-TNF alpha activity. The most important cytokine that is involved in TB meningitis is TNF alpha, more of an immune-mediated process rather than only steroids. So CSF, thalidomide can be given in such group of patients. And some groups are also trying, ironically, interferons, the only drug which is contraindicated in tuberculosis. They are also targeting those are used in severe tubercular meningitis, the extensive inflammation. So these are the newer things that are being tried. We have not yet seen the results of how these are faring. But yes, TB meningitis with the extensive immune reconstitution is a very difficult disease to treat as per now. But yes, at this time, there are no particular guidelines for each and every subgroup or individual case. The clinician has to take his or her decision on their own. So very good discussion indeed. And any other questions that you have? I think we can, Dr. Arun, you want to have any more comments?
Just a small comment, what he described as a squeeze test. Many times you will see for the residents, especially young children coming with cerebellar ataxia. So it is very important, very pertinent to just look at their eyes and try to make them open their eyes against the resistance, close their eyes against resistance, and many a time you will find an opsoclonus. Otherwise, you are going to miss it. You find cerebellar ataxia, you go for an MRI, cerebellitis, but the opsoclonus might be hidden there, and it initially you might not find it, so keep on examining it repeatedly. So there are cases of OMAS you will find. Yeah, that is my
Yes.
final comment regarding these cases. Yeah.
Yeah, very subtle sign that we all of us should be looking for in any child with ataxia. So if you look at opsoclonus, it is a type of a saccadic intrusion which starts with saccadic intrusions, Swayback jerks, ocular flutter. Then you have the highest level, that is opsoclonus. So even if a child with comes to you and you just examine the eye in the primary gaze, even a subtle ocular in saccadic intrusion in the starting phases will just give you a clue that this patient is going to evolve into a frank opsoclonus. So these are all in a continuum. Flutter, opsoclonus, saccadic intrusions, they all come in a continuum. So if there are no further questions, we'll move on to our next topic, that is a journal club that will be presented by Dr. Ila Upadhyay. Sir, please do introduce your resident, sir.
Yeah, she's Dr. Ila Padya. She's a third year resident with us. So she'll be talking about this journal club. Please, Ila, please go ahead.
Thank you, sir. Good evening, everyone. I'm really thankful to the team of IN and Dr. Professor Arun Kolso for giving me this opportunity to present the journal club. So the topic of my journal club is Amaurosis fugax dolorosa that was published in American Academy of Neurology in September 2025. Next slide, please. So, amaurosis fugax is a clinical term that describes transient episodes of vision loss in one or both eyes of varying etiology and duration. It was initially described in migraine, but it is also well known in retinal ischemia, that is caused from a carotid artery disease or a cardioembolic disease. Its occurrence is not well explored in non vascular conditions like MUGAD. Next slide. So, the characteristics of MOG antibody associated disease, that is MOGAD, optic neuritis, has been extensively described, but amaurosis fugax has not been reported as a presenting symptom. Next slide. So, the aim of the study was to investigate whether transient visual loss, that is amaurosis fugax, is a clinical feature in MOGAD patients with optic neuritis. So it is a case series study that is nested within a cohort study. So the cohort included all patients with optic neuritis, selected from all those who were tested positive for MOG antibodies in the Mayo Clinic Neuroimmunology Laboratory between July 2014 to 2024 April. So the patients with MOGAD who met the 2023 diagnostic criteria and presented with amaurosis fugax as the initial symptom of their first event of optic neuritis were selected. So amaurosis fugax here was defined as a transient visual loss affecting one or both eyes, lasting less than 24 hours and occurring without retinal ischemic lesions on eye examination. So the diagnosis of MOGAD, as we all know, is based on clinical testing, laboratory testing, and MRI testing. And we have to exclude the red flags. So all the patients who were falling in the who were falling in the category, they were included, and the patients who had amaurosis fugax as a presenting symptom before optic neuritis were selected. So a retrospective review of medical records was conducted for each patient. Clinical data, findings from the brain and orbital MRI and OCT were collected, and a descriptive statistical analysis was performed. Of the 526 patients with MOGAD, the mean age of which was 35.3 years, and the female, there were 61% females. 350 patients had one episode of optic neuritis. 8 patients with MOGAD were identified with confirmed amaurosis fugax before their first event optic neuritis, that represented around 2 to 2.3%. No amaurosis fugax episodes were detected among 168 patients with aquaporin 4 NMOSD. So this is the the clinical characteristics of the patients who had optic neuritis and that was preceded by amaurosis fugax. So here we can see most of the patients had an AF severity that lasted for less than 10 minutes, 10 minutes, and around 3 patients had a duration of about 300 minutes, 60 minutes, and 20 minutes. Only one patient had amaurosis fugax in both the eyes, but as we can see here, all the patients had a headache and pain with eye movements following and during the AF. So after the amaurosis fugax, a median time of 6 days was there for after which the patients had optic neuritis. Most of them had moderate to severe optic neuritis, and um, and most of them had optic disc edema. So most of the patients were women, 87.5%, and the median age of the patients was 36.8%. All the patients experienced headaches, periocular pain that worsened with eye movements, which persisted even after the resolution of amaurosis fugax. The episodes of transient visual loss had a median duration of 15 minutes, with most episodes lasting less than 1 hour. Patients with shorter episodes, that is less than 10 minutes, showed a median of 3.5 episodes, while the patients with longer episodes, that is more than 10 minutes, had a median of 1.5 episodes. The amaurosis fugax affected right eye in 4 patients, left eye in 3, and both eyes in 1 patient. After a median of about 6 days, 7 patients developed typical optic neuritis with prominent visual impairment. Brain and orbital MRI of all the patients revealed optic nerve enhancement localized to the site of amaurosis fugax symptoms. So the first picture shows the MRI brain with orbital cuts. So the AA picture shows optic nerve enhancement. The MRI was taken when the patient had the amaurosis fugax during that time, and when he had not developed optic neuritis. Then the patient, when he developed optic neuritis, a course of steroid was given and follow-up testing was done. So the follow-up MRI that is shown in the AB figure shows that the enhancement has completely disappeared. The bottom picture BA shows the OCT. So during the amaurosis fugax, there was mild optic disc edema. Then in the next picture, we can see the optic nerve edema had increased. It peaked during the optic neuritis, and slowly with the treatment, the OCT improved and the disc edema disappeared. So after steroid treatment, all of the patients improved. After a median follow-up of about 2.77 years, only one patient experienced a similar episode associated with another optic neuritis event. So this case series identified a subset of individuals who experienced amaurosis fugax in the days preceding the onset of full phenotype MOGAD optic neuritis, always affecting the same eye. All the patients reported to have headaches or periocular eye pain during the prodromal phase. The distinct clinical phenomena was present in about 2.3% of the patients of the first event optic neuritis, consistently affecting the same eye later that led to optic neuritis, which was confirmed with a orbital MRI with contrast. There was a temporal association, same side optic neuritis resolution with corticosteroids, and absence of any other alternative etiology on follow-up. So, MOGAD optic neuritis was considered as an etiology for the amaurosis fugax in these patients. Painful amaurosis fugax in MOGAD-related optic neuritis distinguishes it from painless episodes after carotid or cardioembolic diseases. So, as we know that in patients with a vascular etiology of amaurosis fugax, the event is usually monocular, it is painless, and it usually lasts for about a few seconds or 1 to 2 minutes. In patients who have ocular migraine, The amaurosis fugax is usually bilateral, it is slow, and there are positive symptoms. So the hypothesis of amaurosis fugax in MOGAD is that slow inflammatory progression before optic neuritis leads to headache, eye pain, and transient fluctuations in the nerve conduction that leads to amaurosis fugax. The second hypothesis is that the optic head inflammation affects the choroidal arteries, supplying the intralaminar part of the optic nerve that leads to vasospasm of the arteries and leading to transient ischemia, therefore amaurosis fugax. Then perivenular and perivascular inflammation of the arteries lead to amaurosis fugax that later affects, that causes the inflammation of the optic nerve tissue and leads to optic neuritis. And then on MRI, we see the optic nerve sheath enhancement that causes the compression of the central retinal artery and then causes amaurosis fugax. The limitations of the studies was that it was a retrospective design. The follow-up data were insufficient in MOGAD patients with amaurosis fugax, preventing comparison with non-amaurosis fugax cases. As only the first event optic neuritis was analyzed, the frequency of amaurosis fugax in the later MOGAD is unknown. So the critical appraisal of the article. So were there clear criteria for inclusion in the case series? So yes. Was the condition measured in a standard reliable way for all participants included in the case series? Yes. Were valid methods used for identification of the condition for all participants included in the case series? Was yes. Did the case series have consecutive inclusion of participants? No, because it was a retrospective study. Did the case series have complete inclusion of the participants? That is also no. Was there a clear reporting of the demographics of the participants in the study? Yes. Was there clear reporting of the clinical information of the participants? Yes. Were the outcomes or follow-up results of the cases clearly reported? No. Was there clear reporting of the presenting site or clinic demographic information? Yes. But there was no statistical analysis done. Next slide. So the take-home message is that amaurosis fugax dolorosa is a previously unrecognized clinical prodrome in patients with MOGAD. So recognizing the transient visual disturbances will enable earlier diagnosis and treatment and will improve the patient's outcome. Thank you.
Thank you, Dr. Ila, for that wonderful journal club. We do have a lot of new information coming in regarding the presence of amaurosis fugax. Earlier, we just associated with this with avascular events, but now we are increasing it, seeing in hemolytic disorders also. So, what personally do you have? Do you have a takeaway from this case? I mean, this case series.
Yes, sir.
If a patient of a patient of amaurosis does come to you, so do you want? So the patient is actually giving you a lot of time. And if you see in those case series of 8 patients, like just after amaurosis to the development of vision loss, there's a time interval, least being at least 2 days, maximum up to 9 to 10 days. So patient just give you time before the actual attack and the actual vision loss occurs. So your take on that?
Yeah, so 2.3% of the patients of MOGAD had this history of amaurosis fugax. Also, since it is a treatable condition, so after ruling out other things, like if the patient has the history of carotid artery disease or heart disease, we should rule that out. But since it is a treatable condition, we can go for a MOG antibody testing and an MRI for the patients. Also, the clinical features are also important. Important here, we saw that the time of the amaurosis fugax was more. Usually in vascular cases, it is less. It is usually seconds to minute. So that also gives the clue that the process is inflammatory. Also, one of the patient had a bilateral symptom. So that is also an important clue to that.
So most of our residents are asking, why is it not like, why you're considering this as amaurosis fugax? Why is it not Uthoff's phenomena, something that we see in demyelinating disorders when the temperature raises, transient neurological episodes.
So the patient did not give any history of in like a fever episode or any history of increase in temperature. So that is why we can rule out Uthoff's phenomena. Also in MOGAD, there are chances of increase in the intracranial pressure, but there was no history of this episode occurring during the Valsalva maneuver. Usually, when it occurs with an increase in the ICT, so it is usually unilateral. It is not associated with any pain. But here, all the patients had pain and headache. Also, the patients had papilledema on eye examination.
So that gives you one more clue towards the diagnosis. Like this could be a transient visual obscurations also that we see in raised ICP, that we see in IAH, that we see in CBTs, all those patients which we have. But compared to those patients, we just have only one. Compared to those patients, you have unilateral vision loss, in which TVOs are usually bilateral. In these patients, we have unilateral node.
Maximum of the patients had unilateral.
So this paper does have some flaws regarding the case definitions, how they include these patients, whether these are classical amaurosis fugax, or this can be transient visual obscurations, or do you have uh, transient neurological events that are present, which are not very well defined. So there is some, uh, lack of quality in the inclusion criteria of what patients they are taking. So these can be termed as rather not as classical amaurosis fugax, but like amaurosis fugax mimics. So what a take-home message for the residents, everything that we can get from is patient with transient vision loss or amaurosis fugax or transient symptoms. These are the high-risk patients in which you have to work up aggressively. Whether the etiology is MOGAD, whether the etiology is cardioembolic disorder, whether it's a carotid artery disorder, these have to be evaluated on a priority basis because the time onset between the symptom, that warning sign, and the actual disease occurring is very short. So in your case, it's less than 10 days in most of these patients, and vice versa in any other disorder like giant cell arteritis, carotid plaque disorders, or cardioembolic stroke. They'll also have maximum tendencies in the first 1 or 2 days or 1 or 2 weeks itself. So these patients are the high priority targets in which you have to investigate quickly and rapidly so as to prevent long-term disability. If you have GC and you have vision loss, then that's not going to improve. If you have cardioembolic stroke, then that's going to take a lot of time to recover. MOGAD will also, once you have loss of neurons, that will also have a lot of delay and treatment that will add to the further burden on these disorders. So these actually give you time. So this is the take home that we want to take our residents. Do you have any questions? I think there are no questions regarding this journal. Professor Arun sir, you want to add something?
I just want to highlight a few things. That one is the pain, occurrence of pain, as she has said that it is an amaurosis fugax dolorosa. So in ischemic, apart from temporal arteritis, you are not going to have pain. So that should be very clear that when a demyelinating event occurs, it is usually associated with pain, like we see in classical optic neuritis also, the pain on the eye movements. That is point number one. And second, as rightly pointed out, the duration of the symptoms. And the third, as she said, that sometimes now we have a fair degree of literature of raised ICP in MOGAD. Sometimes they have a mimic like just the idiopathic intracranial hypertension. And sometimes they may present with just initially IH only, and later on, I think there are some cases where they found MOGAD and the other classical MRI features later. So if you have a transient visual loss, you may call it by whatever name, but investigate. The point take home message is that investigate properly. Don't let it go. Make the patient aware that anything where the patient is not able to see properly, even if it occurs for 1 minute, 10 minutes, anything, and when it improves. Like in TIAs, as you rightly pointed out, and later on we got this ABCD2 score. Maybe if we have we follow the more patients, and then we know that in which patients, what are the risk factors that ultimately cause this amaurosis fugax to blow up into a full-blown optic neuritis. And treatment, as you said, that the earlier you catch them, the better you treat them. That's from my side.
Sir. Yes, sir, rightly said, sir. These are the warning signs which have to be taken very seriously. We should not miss out at any point, sir. Dr. Sujit, sir, can you hear us? I think that's not. I think he's not able to join somehow. So
I think
so
we have
we had
one. I had
yes, sir. Dr. Sujit is here.
Is there?
Yes, sir.
Yes, Dr. Karthik, I missed that question.
So no, sir. I just want to say we had a very wonderful discussion
Yes,
regarding.
we had a wonderful discussion. The cases were extremely diverse and very educated because I personally have never seen an opsoclonus and a TB meningitis and never in SSP as well. So they were very educative, and this underlies the importance of examining the eyes in any critically ill patient. You know, I carry my phone and record things from the ICU. Very often you will see ocular dipping, bobbing. Whenever the pons is involved, all these saccadic intrusions come in. So it's very nice. One should actually keep a record of these things for us to learn. So both cases I thoroughly enjoyed, and the journal club was spectacular because the choice of the journal, you know, we see transient visual obscurations in IIH. We also see in, visual aura where they have a scintillating scotoma, or sometimes, they actually have a negative scotoma. And now we have another cause. So like Dr. Arun Kaul said, we need to investigate these things, keeping the clinical features in mind. So, we need to probably do an MRI with fat suppressed imaging, and most of these patients are not just a stroke protocol. So MRI brain in orbit, we need to do in all these patients. I think that would be a take-home message. And to do a good neuro-ophthalmological examination in all patients, critically ill as well. So Dr. Arun Kaul and Ila and Arjun, congratulations on two very good presentations. I really enjoyed them.
Thank you, sir.
Thank you very much. Dr. Karthik, any more questions do we have to take?
No, sir. I don't think that
I think we've had a very good discussion. Maybe, it's Saturday evening, maybe we can wind this up early if everybody is okay. Thank you very much, Dr. Arun, Dr. Arjun, and Dr. Ila. We had a wonderful discussion. Thank you, Dr. Karthik, for initiating and maintaining this discussion. I'm sure that all of us are wiser at the end of the day. Thank you to all the residents and consultants who have joined in. Let's have many more of these. Thank you very much.
Just a submission I had put in a case, if with your permission, just 2 slides. As I discussed it.
Sure, sir. Why not?
Yes, sir. I think we had some question and answers for the students. I think we can play those question answers. Yes.
We have just, Ila, can you just put
Yes,
that
sir.
slide?
Asmita ma'am, can you play my PPT? At the end of the presentation, there are 3 slides.
I think this is a small quiz for all the students who have joined in here.
Just one question. So he's a 10-year-old child and he says कि दिन में उसको तारे दिखते हैं. So but when you ask him more properly, then he tells you that he sees multiple colorful dots in front of his eyes and they last for maybe for seconds sometimes. But otherwise he's perfectly normal and he's not much bothered. But when you ask him that what was he seeing, he keeps on saying this. So this is a 10-year-old child with this symptoms. So can we have the EEG? You just have to, the residents, they just have to comment on the EEG. What all do you see in the EEG? Next slide, please. Yes. So this is, the clinical symptom and this is the EEG. So the most, what is staring at your eyes, can you just, there are some hints in the slide as well. So keep the clinical symptoms in your mind and then try to have a look at this EEG. Where do you see the abnormalities? What is the state of the patient? And then maybe you'll get a clue. If anybody answers,
encourage all the students to have please type in your answers in the question and answers or chat section. Yes, we have an answer.
Yeah, SV, can you please? I mean, I don't know who, Dr.
Suti Kishan Vasudeva. Yes.
Yeah, there are definitely there are occipital spikes. Very good. Yeah, it is awake. Yes. Occipital spikes when Dr. Sapna Mittal has said that occipital spikes when the eyes are closed. Very good. So what is happening when the eyes are opening? what is happening? You see there's a marker for eyes closed and eyes opening. You're very right. Dr. Sapna is very right that occipital spikes are seen when the eyes are closed. So what happens when the eyes are opening? What, apart from the typical occipital spikes that you're seeing, what else do you see when the eyes are closed? See at the posterior leads, what do you see? I don't know whether this pointer is working. No, how do you know this is photosensitivity? But you are going in the right direction, Dr. Sutikshan is going in the right direction. It's not scotosensitivity. If scotosensitivity, basically, scoto means dark. So here the eyes are being closed, and with the alpha, you see there's the alpha rhythm is there. The eyes are closed, and when the eyes open, the discharge also goes off. So that is when the fixation goes off, the discharge also goes off. So it's not scotosensitivity, but it is what is called. Anybody? I've given a lot of hints, so if anybody gives the right answer, maybe we'll next time we'll provide him with. Yeah, this is somebody has replied. FOS, Dr. Sutikshan Vasudeva. So this is indeed fixation of sensitivity. And can you tell us the diagnosis? POS. I don't know what is POS. Dr. Santosh Trivedi has said this is POS. Okay, I don't know whether he wants to say Paniotopolis syndrome. I'm not sure. Achha, FOS. Okay, sorry. FOS. Yes, it is indeed fixation of sensitivity. So where do we see it? No, we don't see it in Jivans. There we have eyelid myoclonia basically. I told you the clinical profile of the patient. In Jivans we have eyelid myoclonia with absences. So here, okay, I think we can go to the diagnosis. Yeah, this is occipital lobe epilepsy indeed. Recently the name has been changed. Can we go to the last slide? We'll have the answers. So this is childhood occipital visual epilepsy, COVE. Initially it was called the idiopathic childhood epilepsy of Gastort. And this phenomena is classically described as the fixation of sensitivity. You take off the fixation and the discharges disappear. Once uh, you take off the fixation and then the discharges come. That is, the eyes are closed, and as soon as you open the eyes, the discharge goes off. So that was this childhood onset epilepsy, occipital epilepsy. So yeah, that was it. So again, it is fascinating visual phenomena, mostly benign as some, that is usually benign, but if there is other symptom, here the patient has this pure epilepsy, that is pure visual seizures, which are very short lasting and simple visual hallucinations. But if it is associated with some cognitive decline, any other symptom, then you have to look for structural causes. So yeah, that was it. If anybody has any comment or anything, so we will be very happy to reply. But otherwise, this is from my side. Yeah.
Thank you, sir. So that was a very interesting question and a challenge of students and everyone present here. Thank you, sir, for the wonderful team efforts that you have put in. Thank you to your entire team. Thank you, and we'll also want to extend our thanks to the IN Digital team,
Dr. Karthik, I think this should be a feature. Dr. Arun, that was wonderful. I really enjoyed that last question. I think we should have 1 or 2 questions for residents at the end of every webinar. What do you say? Just to tickle the intellect.
Yeah.
And, it showed us your, your teaching abilities, and, our professors can teach our residents who join. And, we ask a question which incites the intellect, and then when you reveal it, they'll remember it forever.
Exactly.
So I think this is something which we should include. What do you say, Dr. Karthik?
Yes, sir. I think
a couple of questions like a quiz at the end of it.
I think people are asking for more questions on the chat group.
Yes, we definitely include.
Maybe 1 or 2 we can take and then wind up. We still have time.
They are asking for quiz questions if they have more. I don't think so.
I think quiz questions we can prepare. From the next time, maybe we can have 3, 4
yeah,
or so,
I think we can
5.
Have,
and the team which presents can ask, and the professor in charge can discuss it also.
Yes,
that would be a unique way of, generating interest among the residents in neuro ophthalmology.
Yes. And I
Fantastic
think
questions,
next
sir,
time
and
onwards we'll have
fantastic
some.
cases. We really enjoyed the whole program. Didn't realize 1 hour 15 minutes passing. And I must congratulate both the presenters for an excellent
Yeah.
presentation. It was very gripping, if I may say so. It was not at all boring, very gripping, and we were wondering what each slide will reveal. So, and also I must congratulate you on the review of literature. You have covered it extensively. Congrats to the teacher also, Professor Arun Kaul. Thank you, sir. And I think we can maybe wind up the webinar today, if it's all
Yes,
right.
sir.
It's a Saturday night, so.
So I thank you all the team members from the GV Pant Hospital, Dr. Arun, Dr. Arjun, Dr. Ila. Thank you, sir, for guiding us here, and thank you to the IM team, Ms. Asmita Matle. Thank you all for joining us today. With you all, we'll see you in the next webinar that we hold quite soon, sir. And yes, thank you.
Thank you. Thank you, Arjun.
Thank you very much.
Thank you, Arjun. Thank you, Ila.
Thank you,
everybody. Yeah.
Thank you, sir.
Thank you. Thank you, Dr. Sajid.